Hello, welcome everyone. I'm John Sproul with the Institute of Health Economics, and welcome to people who are online. And thanks to the coming to the Evidence and Practice luncheon series. And today we're going to be talking about economic evaluation in primary care and chronic disease management programs. And really pleased to have Dr. Braden Manns, who actually is a board member of the Institute of Health Economics, but is with the University of Calgary and is going to be starting May 8th as the Associate Chief Medical Officer for Strategic Clinical Networks for Alberta Health Services, and which will kind of keep him really busy. But Braden, pass over to you for a presentation.
Thank you for the invitation. It was good to get invited up because I've got another 6 or so meetings the rest of the day. In advance of taking on this additional role. Did people get the paper that was sent out? And I see some people have printed off the slides as well. Excellent. So I guess this is the third in a series. So I meant to, I think, introduce the concepts of economic evaluation. And I think more broadly, I'll talk a little bit more about how we can use costs and how we can link costs into primary care and chronic disease management. The paper, if you get a chance to read it, this will sort of build on that, or at least talk about some concepts introduced within that. So first off, we're going to talk about just the basics of economic evaluation in the context of a case study. We're going to talk about the relevance of including costs with specific regard to primary care. We're going to talk about an example that was actually done by Scott Clarenbach, some people from the Institute, as well as CADIF a few years ago, that informed how test strips were funded by Alberta Health, test strips for glucose monitoring and diabetes. And then finally, one of the hardest things to do actually is to get the people who order tests and schedule surgeries and write prescriptions to take costs into account. So I think we can educate healthcare providers, but I think we actually need to link it into their accountability framework. So we'll talk a little bit about that, and just to introduce you to blended capitation, which is a different way of paying family physicians that many of you may know something about. It's sort of a pilot project that Alberta Health is pushing forward that we're helping to evaluate. And then at the end, we'll have some questions. And then at the very end, they wanted us to have just a back and forth, a round table around an example to apply the knowledge that you learn here. Hopefully you learned something. So the first thing, the case study. So a 67-year-old woman is seen in primary care. I'm used to having a computer in front of me, so I'll try to talk at you, but I need to glance back to see the slides. She's come in for follow-up for her blood pressure and her diabetes. She's on a few pills for her diabetes and a blood pressure medicine. Her blood pressure is fine. She's had no low blood sugar episodes, but her average blood sugar control, as measured by this A1C test, is above what guidelines would recommend. And so you increase one of her diabetes pills, and you suggest that she monitor her blood sugars intermittently over the next few weeks and come and see you. But you also wonder if she might benefit from a nurse case manager that the primary care networks are looking at funding. So at the end, actually, we're going to talk about what information, types of information you might want to consider if you were running a primary care network and looking at purchasing those types of services, what kinds of information you might need to know to understand whether that's something you should invest in. So the basic principles of economic evaluation, I think probably most people in the room are comfortable looking at evaluating information about whether a new test or treatment is effective at doing what it's meant to do to improve health, or looking at whether it's safe. Economic evaluation essentially extends that, considers whether a new treatment is safe and effective, but it also considers how much it costs, and it considers those things simultaneously. A couple of the principles that are the heart of this are opportunity cost. So just to give you an example, if you had 2 programs, and we all know that resources are constrained, and even in a wealthy country like Canada, we don't fund everything within healthcare. So if you wanted to improve health for people with diabetes, you might consider investing in nurse case managers that help manage blood sugar. And for an average primary care clinic, you might hire one. It might cost you $150,000 per year. Or you might decide that actually your priority is around preventing amputations. People with diabetes are at risk of getting ulcers in their feet and potentially requiring amputations. And perhaps a program which the SCNs are piloting might cost $100,000 to set up and $100,000 to fund every year. The point within health economics is to say that the opportunity cost, if you decide to fund the nurse case managers, are the health benefits that you would have gotten had you funded the second program to try to prevent amputations. So it's less about the cost of the programs, it's about what health you could have purchased with that money. So the opportunity cost of funding the nurse case managers are the health benefits you could have gotten had you decided to fund the second program. And there's three different, so economic evaluation is the usual way that we evaluate opportunity cost or evaluate efficiency, efficiency being the impact of something on outcomes or outputs and the costs that go into producing that output. I'm not going to talk about cost-benefit analysis at all. By and large, what you'll see published in terms of economic evaluations are cost-effectiveness studies. Cost-effectiveness and cost-utility studies measure costs in the same way, but the way that they look at outcomes or measure outcomes is different. So in cost-effectiveness analyses, it's regular units like life years gained or blood pressure, the millimeters of mercury of blood pressure that's reduced, or it's heart attacks prevented. So it's clinical events that are being prevented by and large. Whereas cost utility analysis uses quality adjusted life years gained. Are people familiar with quality adjusted life years gained as a concept? Is anybody not familiar with them? Okay. So DJ, unfortunately, when you showed up to work today, you were pretty sick to your stomach and you were really tired. Actually, you've been late for work because you haven't been feeling very well. And you go to your doctor and unfortunately you're diagnosed with kidney failure. And you need to end up starting on dialysis. Dialysis meaning you have to go back and forth to the hospital 3 times a week, or you have to do your dialysis at home on a day in, day out basis. So your life expectancy, unfortunately, is only about 10 years. And your quality of life is definitely going to be impacted by dialysis and by feeling tired and by feeling sick to your stomach. One of the problems, I should back up for a second, with cost effectiveness analysis is if you have a study that says it's $10,000 to prevent a heart attack or it's $20,000 to improve quality of life in somebody with rheumatoid arthritis, those things aren't very comparable. So with quality adjusted life years gained, we try to get a measure of overall quality of life that's comparable across different interventions and different treatments. So back to DJ. You've got 10 years of life remaining, DJ, in this state where you're tired and you might be nauseated and your limitations at work and you've got to do dialysis every day. But fortunately, a cure has become available and we can get you back to feeling exactly how you were feeling a few weeks ago. But it's kind of risky, so you're only going to live for 2 years, but you'll be in perfect health for 2 years. Or you can stay on your current course on dialysis and you'll live for 10 years, but your quality of life is going to be lower. Which one would you prefer?
Probably the 2 years.
2 years. Okay, unfortunately, treatment's a bit riskier than I thought. You're only going to get 1 year before you pass away. So would you prefer the 1 year in perfect health, or would you prefer 10 years in a lower state of quality of life?
I'm not sure.
Okay, perfect. He's not sure, so he's reached the point of indifference, where he's not sure whether he'd like 1 year in perfect health or 10 years in his current health state. And so he's almost willing to trade off 1 year of perfect health. We find that point of indifference, and actually you're a bit lower than most people on dialysis who are experiencing it. They usually would trade about 6 years of perfect health for 10 years on dialysis. And so that's a utility score or a measure of overall quality of life. It's a preference-based measure. And so people are willing to trade off 6 years of perfect health and quality adjusted, or they would have, rather than 10 years in perfect health, they would have a utility score of 0.6 or 6 quality adjusted life years gained, reflecting lower quality of life. And so when you use that common measure of health benefit in a cost utility analysis, you can compare treatments for people with rheumatoid arthritis, with treatments for people with trying to prevent heart attacks, or with people on dialysis. And you can compare different treatments as well as different disease conditions. So it's a way of trying to determine whether you should put your resources into improved dialysis care or improved heart care or improved care of people with inflammatory arthritis. Any questions on that? Because that's often what we think about when we think about economic evaluations is the quality adjusted life year gained and cost utility analysis. One of the examples we're going to go into is related to that. So then that leads to the question, what's the role of economic evaluation in healthcare priority setting? And essentially, economic evaluation is used, again, when we think about a new treatment or test. If we think about this pendulum that it's going to cost more money, if the treatment is a lot better than what we're currently doing, you might be willing to spend significantly more money, whereas if the treatment is just a teeny bit better than what we're currently already funding, you wouldn't want to spend much extra money. And economic evaluation or cost utility analysis provides a number that helps you balance the additional money you're spending with the additional benefits you're getting. We're covering like 8 lectures within a graduate course in 13 minutes. So there's some additional background information in that paper that was sent out. But when we think about how one might interpret this cost per quality adjusted life year gained, there's been some simple rules that have been put out there based on Andreas Lopax's observation of how these types of studies were used to determine what new medications were paid for in publicly funded health care. And he simply observed that if the cost per quality adjusted life year gained was less than $20,000, those were almost always recommended for inclusion within publicly funded health care. If it was over $100,000, they were rarely ever recommended for inclusion. And if they were in that 20 to 80,000 per quality adjusted life year gained range, they may be recommended for funding depending on other factors. So people at Alberta Health are expert in understanding what these other factors are, because you'll get called by patients and programs will lobby you to increase funding for certain things, and they will talk not just about costs and clinical effects, but they'll talk about the type of person who's gaining that benefit. If it's a child, we might prefer to increase funding for children's health as opposed to older people like myself. And when you actually survey the public, they do preferentially want funds put towards children's health. There might be a differential their preference for funding things that extend life versus things that improve quality of life. There might be certain mental health or cancer. There might be conditions that we're preferentially wanting to push resources to because of perceived need or equity reasons. And then the last one, is this a priority, a stated priority for government? Is it a priority within the AHS business plan? And then, can we afford it? What's the actual budget impact? Okay, so your involvement again. So is health economics relevant to primary care and chronic disease management? So I always ask students this, or physicians or nurse clinicians, if and today I'm going to ask you, what do you think and the person in the black shirt with the glasses looking at me, what do you think the goal of healthcare providers in primary care is?
I guess to provide the best possible health outcomes for people, and try and use the best measures for everybody, and be equitable about how we approach healthcare and policy.
I think that's a great answer. So the answer for people online was primary care providers are meant to improve health outcomes as much as possible for the person in front of them and for the people that they're looking after. So as government, what's the goal of healthcare policymakers at Alberta Health?
like to quote us, we're trying to make sure that we provide the right care in the right place, using the right people and the right tools, right? So trying to make sure that we're addressing the needs and concerns of everybody, but realizing that not everybody has the same concerns and trying to be spread out across that, right? And so using like the primary care networks, I think, are a good way that we're trying to do that, to try and be more encompassing and offer more services and try and attack different areas.
Okay, so treating the right person at the right place at the right time with the right treatment. Okay, is there subject to any constraints? Is Alberta Health subject to any constraints when they're looking at providing therapies and things to the population? Funding, yeah. So actually the only difference between the goal of healthcare providers is healthcare providers often don't think about budget at all. Whereas Alberta Health and Alberta Health Services, they're working subject to a constraint, a budget constraint. So actually, what I would always stress to actually physicians is that your goals are pretty similar. The reality is there's a budget constraint and you need to work as part of the team as well. So how do we help you work as part of the team? Physicians always get uncomfortable because through medical school, they are told that Hippocrates said, I will apply for the benefit of the sick all measures which are required. And we'll come back to the end to say whether in fact that's the only thing that he wrote about. So an example, coming back to the glucose testing strips in diabetes. So this was work that was done by Scott Clarenbach, who's a nephrologist in Edmonton and a health economist, and I think he's the chair of your expert drug advisory committee. He was working with people at CADITH on this, and they looked at the cost effectiveness of glucose testing strips, which actually informed how these things are funded across the country. The situation has changed now because I think actually people are now interested in these continuous glucose monitors, which cost a little bit more, but provide some benefit from a patient perspective. But regardless, we're going to go with the tried and tested paper that was published in 2010 around the cost effectiveness of testing strips. So nearly half, and again, things have changed with the drugs that are now being funded, the pills that are now being funded for diabetes over the past 6 years. But back 8 years ago, the cost of strips actually was a significant portion of the budget when you compared it to the anti-diabetes pills that were being funded. And Canada was spending, I think, $350 million per year in Canada, and these regular testing was recommended through the Canadian Diabetes Association guidelines. They backed off a little bit, but it was recommended for people who were not on insulin at that time. And then half of expenditures on blood glucose testing strips were on people not on insulin. So they did this work. They started off with a systematic review. They identified 7 studies that had randomized almost 2,500 people to testing strips or not. Testing strips on average in this population were costing about $1 per day. And what they found from the clinical trials is that indeed your average blood sugar control was slightly better. So we would think of a clinically significant difference as about a 0.5% change, although we now understand that some medications that reduce your blood sugars actually kill you, and some that reduce your blood sugars actually improve your outcomes. But assuming that you're using medications that improve your outcomes, there is a slight improvement in average blood sugar control. But what does that translate into actually in terms of the complications that people can get from diabetes, like heart attacks, kidney failure, blindness, nerve pain, and neuropathy? Well, what it actually translates into when you put this into a model and say, on average, people with an A1C, let's say of 8.6% like this lady, on average over the next 20 or 40 years, there's about without self-monitoring, there's about a 36.6% chance of the person developing a heart attack. But if we do the self-monitoring and lower the blood sugar just a wee bit, like these studies said, the risk of that's going to go down by 0.4%. So very small changes in the actual complications you're trying to prevent, the heart attacks, heart failure, stroke, kidney failure. And when we use the other metric, the numbers needed to treat, often we think of things as being important when the number needed to treat is certainly less than 100, and all of these are much significantly higher than that. So we have a high quality systematic review that says there's a statistically significant change in blood sugar control, and that may translate into changes in clinical events, but that depends on what medicine you're using. And frankly, it's a bit uncertain. And the cost per quality adjusted life year gained when you put this all together is about $110,000, which is sort of in excess on that quick metric I showed you, in excess of what we would normally fund within publicly funded healthcare. So actually, this again is an example though where doctors can prescribe this and give it to patients, and they're not regulated in their ability to ask them to check their blood sugars. But governments have created funding policies, and Alberta's has changed recently, but I believe it used to be that testing strips, well, they're covered for people on pumps, I think $600 a year for people on insulin, and $400 if you're on pills, and $200 if you're not. That might have changed in the past year, and I'm embarrassed to say I don't know exactly what the current coverage is. But governments across the country have actually used the results of this study to inform how they pay for testing strips. So the message for primary care is these testing strips, patients don't love testing, you can imagine. And they're testing, but they're not actually, or if they give it back to their doctor's not necessarily even looking at it. So the recommendation would be generally you don't need to be testing if you're not on insulin unless you're making a change to therapy or somebody's getting low blood sugars as a result of it. And it provides very small and uncertain improvements in health outcomes at significant costs. So one of the problems is, though, how do you get physicians or nurse clinicians who are seeing people with diabetes to actually take cost effectiveness into account in their everyday practice? And this is a challenge. Unless the government's simply going to say, we're not paying for it, you have no access to this, then they often open the door a little bit, and then you have to get physicians and nurse clinicians working with partners with you. So one of the, in this new job I'm taking on with strategic clinical networks where value for money is important, it's going to be important to partner with physicians, not just within the limited projects that the SCN is running or pilots, but in the broader healthcare system. And there's probably several things that are important. Physicians do not receive education on value for money. They go through medical school and they just want to learn about medical stuff and tests and treatments, and they don't know how much things cost. It's not that they wake up in the morning, try to spend a whole bunch of money in bad ways, but they do direct about 70% of healthcare expenditures through the tests they order and the treatments they prescribe and the admissions that they direct. But clearly there's a role for education of physicians, and actually some of the groups are doing a very good job of actually building this into the care pathways that are developed to the SCNs. And locally, actually groups of physicians, even in primary care, actually we generally, about 90% of the things that I would do as a kidney doctor are in about 12 different things. Starting somebody on dialysis, treating blood pressure. We see a lot, a small number of things a lot. And so so it's not that hard to be doing this for actually most of the stuff that we do. So you need to think, does this treatment actually work in comparison to what I'm already doing if it's a new treatment, or is the test that much better? And how much more expensive is this than what we might currently have, and are there opportunities to use the cheaper thing in people at the start and only move to a more expensive thing when the person hasn't responded to the first line therapy? Can we actually take the decisions, the prescribing decisions, out of the physician's hands and put it into a protocol? The physician simply says, follow the anemia protocol. And in the anemia protocol is built in the cost-effective ways to use those types of agents. As I say, there's clinical pathways that are being developed and disseminated for heart failure and COPD. Can we make sure that those line up with cost-effective care and actually that they line up with the way that the formulary, Alberta Blue Cross for the seniors and for the non-group plans, that they fund these things, because this frustrates physicians when the guideline says one thing and the formularies provide things in a different way. But the guidelines may not take costs into account, and formularies need to. So when you're trying to help physicians say no based on cost effectiveness, which does come up, and we want them to be good stewards of resources, we need to make sure that physicians remember that they have an obligation to the patient, but that they also have an obligation to society. And when resources are constrained, that taking, seeking to maximize health of the population is a reasonable thing to do. So when we've worked with local groups, we often try to take these decisions out of the physician's hands at an individual level and just get them to work consistently with what people have agreed on are good standards of care. So how do we do that? Well, if we can get guidelines to take cost into account, and we can get local guidelines for care of patients, which we've done in many areas, helping physicians understand that formularies like the Alberta Blue Cross formulary are not there to ruin their day. They're actually there to help guide their care in ways that are cost effective. And also developing local guidelines that will manage the care of most people within the program, so that you don't have to make that, think about whether I should be using this expensive new medication. No, I'm just going to start you on the pathway. And if you fail the first couple of medications, you'll get escalated. But by and large, most people will be treated with the older, less expensive medications and tests. So coming back to Hippocrates, he didn't just say that we have to do everything for the person in front of us. He actually said that we should avoid the twin traps of overtreatment and therapeutic nihilism, not doing anything. And that remembering that we're not treating a fever or a cancerous growth, but we're treating a sick person whose illness may in fact impact the person's family and economic stability, and that their responsibility of the physician includes these related problems if they're to care for people who are sick adequately. And that you remain a member of society with special obligations to all fellow human beings, not just the person in front of you. And that there's an art to medicine, and that sometimes that's stronger than the surgeon's knife or the chemist's drug. So education's one thing, but to be quite honest, physicians are educated up the yin-yang, and it's hard to get their attention. And so to really help them use economic evaluation within primary care and other specialties, I think we have to embed this into the accountability framework and the way that physicians practice. And we're starting to do this we've got a pilot project within nephrology provincially, kidney care provincially, and I'm going to be encouraging this in other content areas as well. So physicians are independent practitioners by and large, and even within the salary plans that exist for specialty care, people don't necessarily, whether they're practicing in accordance with cost-effective care is not tracked currently. So we can do this with something called key performance indicators, and I will tell you that one thing I've learned from speaking with physicians is actually they don't like the name key performance indicators because it suggests that they're doing a bad job, they're not performing well. So they prefer the term indicators of high-value care. And we have to work with physicians when we're creating these indicators of high-value care. Physicians there's a specific process that you can go through to build these. I'll show you some examples on the next slide. It's not that difficult. You have to get physicians buy-in though, and you have to be able to measure them accurately so that when they get their report back, they believe the results. And physicians are competitive, so they will tend to want to improve. We've seen that with bone and joint, where the quality of the joint replacements that they do has improved over time, and there's less variability because we're simply measuring and giving it back to physicians. Enforcement of these things always comes up as an important issue. But if the indicators represent high-value care, then this is something you can embed into practice and get physicians partnering on particular areas. So in nephrology, we've agreed on 5 different indicators of high-value care, one around increasing use of home dialysis, which we've really been very unsuccessful at doing across the province until recently, when we're embedding physicians as partners more fully. But if we can get home dialysis increased, the use of home dialysis increased, which is less expensive, just as good, that will be a win for all sides. Preemptive kidney transplantation. If I was to develop kidney failure, there's only about a 1 in 13 chance that I will start with transplant, which is better outcomes, better quality of life, and less expensive. 12 out of 13 times I'd start with dialysis. So another thing that we can embed into physicians' accountability. And then documentation of levels of care, making certain that when people start dialysis, that we know what their goals of care are, so that we can honor those, and that we don't spend additional resources doing things that a person may not have wanted done to them in hospital. So these are the kinds of, these would look very different for cardiology, they'd look very different for primary care, but these are the kinds of indicators we can embed that take costs into account, and also effectiveness into account. So who has heard of blended capitation within the Alberta context? Okay. I can see that we've, I know that there's various parts within the ministry. So Alberta Health actually worked on this and put this forward in partnership with the Alberta Medical Association, the primary care part of that. It's been slow to take off, but the goal of the new compensation system, we know that about 84% of primary care physicians are paid fee-for-service in Alberta, or that's been historically what the average is, compared to about 73% across the country. And the goal of the new compensation model, which pays physicians in a different way, is to increase access for Albertans within primary care, to allow physicians more flexibility in how they provide services, so that they don't have to see the whites of a person's eyes to necessarily help and direct care, and to give government more at least advance warning of what the budget's going to look like and make healthcare more sustainable. So blended capitation is it's a version of what Ontario implemented about 10 years ago in primary care. So 85% of a physician's salary is based on the number of people in their practice, the number of people based on sex and age and the other health conditions that people have. You receive a certain amount each month. And then 15% of the physician's payment is based on fee-for-service. So if you see somebody in the office, you get an extra amount of money, 15% of what the original fee-for-service claim would have been. So it's meant to allow physicians to change their model of care so they don't have to see a patient to renew their prescriptions. They don't have to see a patient to order lab tests, so they can talk to patients on the phone. They can direct the nurses who can provide care without seeing the patient. It's for a specific basket of service, the most common services that are provided within primary care. As I say, the capitation amount is based on how old and how many conditions a person has. So while this is a change in the way physicians are paid, it's being rolled out with physicians understanding what the goal of the model of care is, that the government wants to see improvements in access to care, so less time waiting to see a physician, to see improvements in continuity of care, that they would see the same physician, but that they'd be cared for within the same medical home or the same group of physicians. They're tracking quality, comprehensiveness, efficiency of care, so things where they're implementing cost-effective care. They're tracking that. They're looking at patient experience, looking at whether complex patients are receiving multidisciplinary care, looking at the referral rates to specialists, and whether patients then subsequently interact with emergency rooms or hospitals. And these outcomes are all being tracked with different data sources. They're actually interviewing patients to get their experience, to talk about, they're measuring directly from the electronic medical records wait times for patients. They're doing surveys they're doing interviews with the healthcare providers and members of the healthcare team. And then they're using Alberta Health Services data to track utilization. So a pretty comprehensive evaluation which cost effectiveness is embedded into. So just to give you an example, you can't actually read this, but some of the things that are being tracked are use of particularly cost-effective tests like fecal immunohistochemical testing for colorectal cancer, which saves money and improves outcomes in comparison to nothing. Like smoking cessation, things like prescriptions of certain types of blood pressure medications, which also save money and improve outcomes. So family physicians are aware that these things are seen as important. They know what success looks like.